Welcome, everyone, and it's a pleasure to be speaking to you and to be participating in this workshop. I appreciate the introduction and just want to add that, um, I've been doing this for a long, long time. If there is something about a standard monograph recommendation or publication that you don't like, and who among us has not read one of those documents and seen something that they don't like, then chances are I am probably the one to blame. The outline of this presentation is simple and straightforward. We're going to be introducing LVPs as a pharmaceutical dosage form, and I will be the first but not last person to talk in this workshop about the challenge with respect to large volume parenterals and managing extractables and leachables. The bottom line is, if you think of pharmaceutical drug products, or but as they're called, pharmaceutical dosage forms, that's a pretty large and diverse population of items. You can think of pills, liquids, items that are injected, items that are applied to the eye, so on and so forth. And the practical reality is that pharmaceutical dosage forms are so diverse and so varied that it's impossible to manage them as an entire population. And so, in order to regulate them and in order to properly qualify them, we need to break them up into smaller groups. We need to classify them. And generally speaking, there's two ways to classify pharmaceutical dosage forms. The first way to classify dosage forms is based on their route of administration. In other words, how is the medication taken? Is it taken orally? Is it applied to the skin? Is it injected? Is it inhaled? Is it applied through the eye? And so on and so forth. And we can differentiate drug products based on the route of administration. The other way to categorize dosage forms is on their physical form. So we have solid dosage forms like pills and tablets, semi-solid dosage forms like, again, ointments and creams that are applied to the skin. We have liquid dosage forms such as, things that you take through your mouth, things that are injected, and gaseous dosage forms that are inhaled. Focusing specifically on parenteral dosage forms, parenteral dosage forms are those dosage forms that are injected through the skin to allow the administration of the drug product. Okay, so anything that's injected, actually anything that it's injected to the body, predominantly through the skin, is a parenteral drug product. Now, there are many different injection sites in the human body, and parenteral dosage forms can be differentiated based on what the target is. So, for example, an intramuscular parenteral dosage form is one that's targeted to be injected in the muscle. An intravenous parenteral dosage form is one that's targeted to be injected into the vein. We're primarily going to be speaking about intravenous parenteral dosage forms. Intravenous parenteral dosage forms can be differentiated on the basis of two properties. Firstly, by the type of packaging, whether the dosage form is packaged in a single dose unit or a multiple dose unit, or more useful to us, they can be differentiated based on volume. So by definition, by USP definition, A small volume parental is a unit dose parental preparation whose volume is less than or equal to 100 mils. Okay. A large volume parental, which is the focus of this entire workshop, is a liquid parental preparation whose unit dose volume is greater than 100 mils. So that's what an LVP is. It's a single dose injection that is intended for intravenous use and is packaged in containers labeled as containing more than 100 mils. Characteristically, LVPs are packaged in glass bottles or large volume flexible containers. The volume of large volume parentals is and can be quite large. It starts at 100 mils. It can be as high as 1 to 2 liters. And in fact, there are LVPs that are as large as 5 liters. LVPs are sterile preparations that are predominantly sterilized in their container via heat, although some are sterile filled. They're pyrogen free, they're essentially free from particulate matter. They contain no antimicrobial agents. They are generally isotonic, and LVPs are generally used more long term. It's relatively rare that you get an LVP once and that's the end of the therapy. LVPs tend to be used more frequently than that. And it's not uncommon that an LVP is a chronically used dosage form. In other words, LVPs are administered for the duration of a person's lifetime. Well, types of LVPs. LVPs generally serve four purposes. They can be hyperalimentation solutions. In other words, they are solutions that provide patients with nutrition. Okay, they uh, alimentate a person's taking into nutrition through eating. They are a cardioplegic solutions. In other words, electrolyte solutions. They can be used for irrigation. They can be used for peritoneal dialysis. And there are other applications as well. For example, pre-mixed drug product LVPs. They're actually used for therapy. LVPs can contain blood derivatives, drug premixes, and or contrast agents. The composition of an LVP, again, a vast majority of LVPs are aqueous or liquid. So the vehicle is either water, a water miscible vehicle, or a non-aqueous vehicle. The LVP dissolved in the vehicle will be the active ingredient, the drug substance. And an LVP may contain one or more added substances. For example, tonicity adjusters like sodium chloride as an electrolyte or dextrose as a non-electrolyte. Buffers to control the pH. Antioxidants, obviously to prevent antioxidation. Preservatives, complexing agents, surfactants, so on and so forth. So an LVP can be as simple as sterile water for injection. It can be as complex as a lipid emulsion that contains 20% lipid emulsifiers, so forth. That's essentially represented in this particular slide. Again, if we think of a compositionally simple LVP, we can think of irrigation solutions. Sterile water for injection. What could be more simple than that? 9/10% saline, which is essentially salt and sodium chloride in water, and lactated ringers, which is a slightly more complicated formulation. And then again, it can be extremely complicated. The nutrition solution or a pre-mixed drug product, for example. Uh, Now that we've talked about what the contents of an LVP is, useful for us to consider, well, what is it? What is an LVP contained in? For years and years and years, LVPs were almost exclusively contained in glass. Okay. There are a number of reasons which we'll go into in the next slide. While that's a why that's a highly undesirable circumstance. So, oh, I don't know, maybe 40 or 50 years ago, flexible containers for LVPs were first introduced into the marketplace. And those flexible containers were primarily based on PVC, DEHP plasticized PVC. You know, flexible, clear, number of desirable characteristics for flexible PVC-based containers. The issue is that containers were 40% by weight, plasticizer DEHP. That particular plasticizer has certain health issues associated with it, and is currently banned in a number of different countries. And so, as packaging for LVPs evolved, the flexible PVC containers were produced by EVA films, ethylene vinyl acetate films, and the combination films, multi-layer films, polyolefin films, so on and so forth. And today, in modern LVPs, a vast majority of LVP containers are either EVA or multi-layer films produced by a blow fill seal a technology. More or less, this is what packaging for an LVP looks like. Again, people say, "Well, gosh, LVP is simple; they're a bag." Well, it's a little bit more complex than that. Certainly, the primary container for an LVP is a bag, but it can be a complicated. It can be a complicated bag. So, for example, here we show one of the more recent innovations in LVP packaging, which is a multi component bag, a bag that contains a bag within a bag. The reason that that kind of container closure system evolved is because it became extremely difficult to optimize the formulation of a complex LVP. Think, for example, of an LVP that contains both a lipid emulsion and a dextrose, an energy source. And the lipid is more stable at high pH. The dextrose is more stable at low pH. So if you attempt to put the lipid and the dextrose in one formulation, that formulation is unstable. The beautiful solution to that is to develop a multi-chambered bag where the lipid emulsion and the dextrose is isolated until the time of use. At time of use, the seals between the chambers is broken and the solutions are mixed. So the mixed solution at intermediate pH only has to exist for a relatively small period of time. So the bag, so yes, the container is a bag, but the bag isn't necessarily simple. In addition to the bag, of course, you have to get into the bag. The drug product in the bag has to get out. And so you have access ports attached to the bag. That access port will consist of the port. It may include an elastomeric septum. So all of a sudden the bag is becoming a little bit more complicated. There's printing on the bag. People have to know what product it is that they're looking for and all the important details. So there's printing on the bag. The bag is typically contained within an overpouch. Many of the plastics that are used to produce these bags aren't very good water barriers. So, in order for this product to have a long shelf life and for all the water not to come out of the bag, they need to be in an overpouch. Okay, so the system is beginning to get even more complicated. That overpouch will have printing or a label attached to it. Inside that overpouch, there may be auxiliary items like an oxygen absorber, for an example. A desiccant might be another example. So all of a sudden, the packaging system for an LVP is not as simple as, hey, it's just a bag. You will find a number of materials of construction go into this container closure system. The more commonly encountered items are polyethylene, polypropylene, PVC, and EVA, because that's what the container is made out of. You may find multi-layered containers with nylon as a barrier. But nylon provides a barrier layer. Many of the injection sites are made of polycarbonate. They don't need to be, but they are. The injection site will have a rubber septum or so on and so forth. So there's elastomers. So an LVP packaging system can be relatively complex in terms of its materials of construction. Okay, so let's get back to the why in the world did people develop flexible containers? Well, the most obvious shortcoming of glass container is that if you drop it, it breaks. So the most obvious advantage of a flexible container for an LVP is that it's durable. You can drop it, you can punch it, you can do all sorts of things to it, and it won't break. It'll still be intact. Another practical reality is that a bag is significantly lighter in weight than a glass bottle. So it's cheaper to ship. It's cheaper to ship LVPs packaged in plastic containers than it is in glass. The other thing is that a bag will collapse so that it empties completely. Okay, and I mean, we live in a world where for every advantage there's a disadvantage. The most important disadvantage with flexible containers for LVPs is that they're interactive. Glass is inert. It doesn't materially interact with the drug product that's packaged in it. Plastic is generally, at least flexible plastic, is not generally inert. So the drug product that's contained in the plastic container will interact with that plastic container. There's two types of interaction. There's leaching and absorption. In leaching, a substance that's originally in the container migrates into the drug product and becomes an impurity in that drug product. Obviously, we don't want our drug products to be impure. So that's an issue. That's an issue relating to leaching. Substances that leach into a drug product from its packaging system under the conditions of which the packaged drug product are stored and used are called leachables. The other interaction that we're certainly not going to talk about in this presentation is the possibility that the packaging system might absorb substances out of the drug product. So it's a two-way street. Substances can be leached from the material phase into the product, or they can be absorbed from the product into the packaging. And when that happens, you end up with a subpotent drug product. There may be maybe a product that doesn't have the shelf life it's supposed to have, or so on and so forth. So neither of these effects are desirable. The effect that we're going to specifically speak to is leaching. In order to establish what safety, but patient safety impact a leachable might have, you obviously have to measure the leachable in the drug product. You have to know what that leachable is. because its identity dictates how safe or unsafe it is. It dictates its toxicity. And you have to know how much of that leachable is in the drug product because that establishes the dose, the amount of this leachable that the patient is exposed to. So the drug product has to be tested, has to be analyzed for leachables. Okay? There's no alternative. Unfortunately, there are two characteristics of LVPs, two unavoidable characteristics of LVPs that make the testing of the drug product for leachables more difficult. One of those characteristics is composition. Again, if the only LVP marketed in the world was sterile water for injection, we wouldn't be having this conversation. Sterile water for injection is an extremely, and maybe it's the easiest test matrix out there for screening for leachables. You can screen sterile water for injection for leachables at extremely low concentrations. Unfortunately, sterile water for injection is not the only LVP. There are chemically complex LVPs out there, like lipid emulsions, blood related substances, where it is extremely difficult to screen the drug product for unspecified leachables. Okay, so composition is one problem. Daily dose volume is the other problem. LVPs are large volumes. As the volume goes up, the daily dose or the patient exposure to a leachable increases. And that means you have to be able to test the drug product for leachables at lower and lower concentrations. So not only is it becoming harder to screen the drug product because of compositions, you have to screen the drug product at lower and lower concentrations. This issue, this challenge is reflected in the analytical evaluation threshold. What the analytical evaluation threshold is, it's a tool that tells analytical chemists what substances, what leachables in a drug product they need to report to a toxicologist for safety assessment. In other words, what substances they need to find, identify, and quantify. And the way that the analytical chemist does that, at least for organic compounds, is through chromatography. So we're going to illustrate the concept of the AET with a chromatogram. I don't think I need to explain a chromatogram to anyone, but a sample is injected into a chromatograph. The output of the chromatograph is a chromatogram, which is a set of peaks, a set of chromatographic peaks, where each peak represents an individual leachable, and the magnitude of the peak represents the concentration of the leachable. So the way that the AET is utilized in a chromatogram, in other words, the way that we establish what leachables need to be identified and quantified, is to draw a line on the chromatogram at the concentration equal to the AET. Any peak that's above or equal to the line needs to be reported for safety assessment because it's potentially unsafe. Every peak below the line does not need to be reported for a toxicological safety risk assessment because it is safe regardless of its identity. That's how the AET is derived. That's the scientific significance of the AET. What these three lines in this particular figure show is the AET for three different types of dosage forms that differ significantly with respect to their daily dose volume. So for a meter dose inhaler, where the daily dose volume is measured in microliters, The AET is relatively high in the chromatogram, and we only have two peaks that we need to be worried about. For a small volume parental, where the daily dose volume might be, say, 50 mils, okay, now the AET line is a little bit lower, and we have more peaks in the chromatogram that we have to work with. For LVPs, where the daily dose volume is typically measured in liters, the line is down here, and you see that we're essentially playing in the grass. Many peaks need to be identified and quantified and reported to the tax assessor for safety assessment. And the issue is not that it's many more peaks, it's that these low peaks, these small peaks in the chromatogram are generally more difficult to assess. It's the information for identifying these compounds is usually less rigorous, and once they're identified, they tend to be uncommon compounds, and so it's hard for the toxicologist to be able to find good data for these compounds. So the issue to the analytical chemist is, how low can you go? How low can you limbo? It's as simple as that. The AETs for LVPs may be so low that even with state of the art, best demonstrated practice analytical methods, you just can't detect that low. And if you can't detect the compounds, they obviously can't be safety assessed. And if they can't be safety assessed, then the patient health risk can't be established. That's the LVP challenge. That's the reason we're together for these next 2 days, for other presenters to give you insights as to how that challenge can be managed. Thank you very much, and I look forward to interacting with you and answering your questions.